This conference will now be recorded.
Okay, good evening, everybody. It's Labor Day, September the 2nd. I'm Rick Davis. I am in the hot seat tonight, and we have a couple of I think we have three new guys, but we don't have a lot of people that have questions, which is good. So I think we'll have time for everybody. And those of you who didn't have questions, if you think of any, we probably will have time to take them. So I want to give a quick thanks to our sponsors, Bayer, Novartis, Johnson and Johnson, Myriad, Telix, and Blue Earth. And with that, we're going to dive right into our first gent. That is Brian Hack in Idaho. Jimmy, you got an Idahoan. Did you see that on the thing? You can
Of
send him a
course I saw that.
message.
Of course I
Yes,
saw that.
of course you saw that. So
Hello, Brian.
Good evening.
I was born in Boise.
Okay, I'm in Eagle, so I'm just down
Up
the
the
road a
road?
bit. Yeah.
Or is it up the road or down the road? I can't.
Uh, I would call it down the road, but I guess
Yeah,
it's your
you're right.
perspective.
You're right. Well, you're older
Uh,
than me.
yeah, Rick, you want me to start right away? I'll jump right in other words?
well, I'm going to ask you a few questions to lead you through the process because it makes it a little easier for us. If you don't mind, Brian, and then we'll give you plenty of time to talk and ask your questions and everything else. And I'm
Perfect.
so glad you came out of the witness ID program as well.
Thanks.
Jimmy had a beard yesterday, but he doesn't have one today. Um,
I'm living an honest
so,
life. Honest life,
so, Brian, how old are you?
I'm just turned 66.
Okay. And I heard you say you live in Eagle, Idaho?
Correct.
Okay. And when were you first diagnosed?
That would have been December 2020.
Okay. All right. Do you remember your Gleason score and your PSA level when you were diagnosed?
Yeah, I had a Gleason of 3+5 and two cores, 50 and 90%. I had some Gleason 7 and 6, but the lateral wall and the apex combined was greater than 50% of my prostate was involved with cancer.
Okay. And what was your Gleason score?
Yeah, that was a 3+5 in two
Sorry,
cores.
what was your PSA? I
Oh, yeah,
misspoke.
sorry. Yeah, 22.8.
Okay, got it. So they they only found it in two cores, but it was still in 50% of your
Yeah,
of the gland, right?
the I two cores, yes, and the rest of the prostate gland was sixes and sevens, if that makes any sense. So it was
Oh,
six
okay.
sevens,
So
two eights, and it was a blind biopsy. And PIRADS 4, I should mention that too, on MRI.
so how many cores did they take in total?
I'm going to say, I was looking up that, trying to find that biopsy report. I'm going to say they took 12, maybe 12.
And how many were positive, would you say?
One, two, three, four. I would say about five of the 12. I know the
Okay, got
math
it.
seems a little fuzzy, but that's what I was
It's okay.
told.
No,
By
it's
by
close.
combining the MRI with the biopsy is how they got to 56% or so of my prostate being involved.
Okay. So they did do an MRI, but it was still a blind biopsy?
Yeah, they
Or
did
the
an
MRI?
MRI first. They did an MRI first in December, and then January was my blind biopsy.
Okay, why didn't they use the MRI to guide the biopsy?
Well, we live in Idaho, and so, you know, we don't have the latest and greatest equipment up here.
Okay. So who was this urologist that you first saw? Where was he?
Yeah, he's a local urologist here, Dr. Williams. He's highly respected, and you know, it was right in the peak of COVID too, so um, that was a little tough.
Okay.
And if Rick, if I may add one thing to my history,
Sure.
2016, I had my previous job and previous primary care physician did a wellness exam, and my PSA came back at 4.6 in 2016, and he just performed a DRE, said he didn't feel anything. I did not get a referral for MRI or urology, and then
Okay.
hop, skip, and a jump through, you know, changing jobs, changing locations, and ended up in Idaho in 2018. And then 19 was, I finally found a good PCP, but he didn't do a PSA test in 2019. He did it, however, in 20, and that's
Okay.
when my PSA
So,
was 22.8.
right, right. So,
Okay.
what was the first lot of treatment that you did back in 2020?
I had started the ADT. I decided to go with the radiation, so and ADT. So I started my Eligard shot, oh excuse me, Firmagon shot for about 3 months, and then switched to Eligard, and that was starting in April of 2021. I had
Okay.
some issues with my insurance company, but
Okay.
um,
And what type of treatment? What type of treatment of radiation treatment did you get?
So end of July of 2021, I had 92 seeds of palladium 103 low dose brachy, and also the space ore. And then that was the end of July, and then October was pretty much 25 sessions over 5 weeks of IMRT.
Okay. So that's sort of the gold standard. But 92 seeds is a lot.
Yeah,
Uh,
I definitely felt it. I still
that's the
feel it. I
most
have
I've
some
heard of.
92
Because
seeds of palladium 103. Sorry.
yeah, I had seeds too, but I didn't have as many as 92. I think it was about 57 or something. Now, how long did you do the ADT for?
18 months, and it ended October 2022.
Okay. And then at that point, were you undetectable?
I had a nadar between 0.11, 0.17 for about 15 months. Testosterone was slowly coming back. Um, and for a while there, life felt pretty good.
And how high did your did your PSA continue to climb from that 0.11 and
Yeah,
then come down again, or did it just go up and keep going up?
just kept going up. Rick, by the way, full disclosure, I know Jerry and I know Henry from another group. So um, thanks for having me here. I want to
Okay.
start by thanking all you guys. Yeah,
Okay.
so January 0.51, and then in about April, I think it was 2.5, and then we just started doing them every month, and it went from 2.5 to 5.9 in May, 9.0 in June. July was 14.8. So it's
Are we
doubling.
we're talking about July of 14 of 23, right?
No, 24.
Okay.
I had
Hold on,
Nader.
hold on.
I'll tell you that.
Let me ask the questions, otherwise we're going to get confused. So you finished your ADT in 1022,
Correct.
correct? And at that point, what was your PSA? 0.17?
0.11.
0.11. Okay. And then it continued to climb constantly through all of 23.
Negative. It was pretty much nadir.
Okay, so it stayed constant through, it stayed constant. I mean, the reason I'm asking this is because in my own case, and I had the same treatment, it went all the way up to 1.97, and then it came down again. But what
Yeah.
you're saying is for you, and I did a little longer ADT than you did, but for you it stayed at 0.11 through 2023, and then in 2024 it got up to 0.51, and then by June or July you said it was at 14.0. Is that right?
Yeah, 14.8 as of July.
Okay, now you were still seeing Dr. Well, no, I didn't ask you. Where did you get your radiation therapy?
Yeah, I had to fly to Seattle for the seeds, and I had the IMRT locally.
And in Seattle, was that at the Seattle Cancer Center at Hutch?
It was Swedish hospital.
Oh, you did it at Swedish. Okay.
Mm-hmm.
Now, when your PSA started to climb in 24 this year, who were you communicating with? Dr. Williams or Seattle or your radonc?
Yeah, I was communicating with my PCP and my urologist, and I asked for a reference for a medical oncologist at this point because I felt things were going in the wrong direction. So I met with a medical oncologist here, and as my PSA continued to climb, we repeated the MRI. We had a PIRADS 2, and my my prostate volume was only 19 mLs, but the density was 0.31 milligrams per milliliter
Yeah, okay,
squared.
but those
So,
statistics don't really mean a lot at this point.
okay,
More important was, did they do a PSMA scan when they
yes,
did another MRI? And
yes.
when did they do the PSMA?
When my PSA was 2.5,
And what month was that?
or that could have been 5.9. That was either April or May. I'd have to look it up. I'm sorry, I don't have all of
Okay,
it.
and what did they find in that PSMA scan?
Nothing.
So in April, the PSMA scan was negative despite your PSA being 5.9.
Correct.
Is that right?
That's correct.
Okay, so now we're in the beginning of September. And before I ask you about where you are as of this moment, have you done any genetic testing?
I did the germ testing. I have no BRCA ones, twos, or any of the other 30 odd genes they look for in a blood test.
Okay, was that through Promise that you did that?
I don't know the answer to that, Rick. I'll have to get back to you on it.
No, it doesn't matter. It doesn't matter. When you said 30 odd, I suspected you did the color. You did it through color, and which is what Promise uses. Um, Let me ask you a couple more questions, just for housekeeping. Are you signed up, Brian, for our reminders?
If not, I will make sure I do that.
Okay.
I've seen some of your videos on YouTube though.
Okay. So it's easy to sign. You can put your email address in the chat window. You can send it just to me. But if you give me your email address, if you don't want to do it publicly, just send it to me and we will sign you up. Are you a veteran?
Not a veteran.
Okay. I'm asking that question for Captain Jim. And how did you hear about us?
I heard about you through another support group, and two gentlemen I know from that group are here tonight.
Okay. So, now let's get back to the meat, which is you have a PSA right now somewhere around 15, and what are you doing for that?
Well, um, I had a second biopsy done. So my MO said that I'm a complicated case. My PSA is doubling every 5 or 6 weeks. Um, there was nothing on my PSMA gallium 68. She sent me down to UCLA. I have family and friends down there, so I've hooked up with Dr. Robert Ryder. He's the director of urology down there. So
Yeah,
far,
but
so good.
he's not the guy to see. The guy you need to
I,
see is Matthew Reddick. Has
well,
he set
we're
you
getting that's
has
part of the
he
reason
set
I'm
you
here.
up?
But I
Has he
I've
set
given
you up with Matthew Reddick yet? I
I'm
know
just I'm
Ryder
just
is.
I'm trying to backfill as quick as I can.
Okay.
I'm looking for a GU medical oncologist, and that's one of the reasons I'm here tonight.
Okay, so we can
Um,
help
but
you.
but I also want to let you know I did a fusion transperineal biopsy when I was down there with my PSA of 9. That was back in June, and 16 cores, all benign. So it's not coming
Yeah,
from my
but
prostate.
yeah, but I don't understand why. I mean, I'm sorry to be so blunt, but
No,
why, after you've had all that treatment, would they even put you through a transperineal? Your
they
your
they
your your primary's being treated.
they
You
felt
know
for
what?
some reason they felt it was possibly still in the prostate. So we had to rule that out, and we have.
Okay,
I
I'm sorry you had to go through that. I really am. It
all right.
bothers me when they do these procedures, which are nuts. I mean, the chances of you having after 97 seeds and across your pelvic girdle, the chances of you having disease in the prostate are slim to none. The fact that it doesn't show up doesn't surprise us because sometimes we know that happens. You may not. One of the reasons it may not show up is because you may not make PSMA. So what they
I
should have done is an Axumin scan. Did anybody talk to you about an Axumin?
So I was scheduled for an Axeman, and Dr. Ryder said, "You know what? I want to repeat the PSMA PET." And I said, "Fine." The PSMA PET I had was up here, and I scheduled my PSMA PET down in Southern California. I got into the latest and greatest whiz bang CT uh, PET scanner, and I got the results just a couple days ago. So
And
that brings me to this. They found two Mets in my retroperitoneal lymph nodes, bilateral, and ranging from low to high as far as uptake goes. So I was under the same suspicion that I did not have the membrane antigen. Dr. Ryder felt that we just needed more PSMA to find it. So I guess we can rule that one out. And I do have at least some membrane antigen. So
right,
right now I'm dealing with two Mets, two known Mets. There's some other suspicious lesions, but I think those are old injuries. They're not really related to cancer.
okay.
So
So the best advice, and then I will turn it over to the guys. The best advice I can give to you is to allow a GU medonc and not a urologist to navigate you on what your next treatment steps should be.
agreed.
Okay. Now, we can send you to people in Seattle. We can send you to people um, in San Francisco. We can send you to people in Los Angeles. Which so if you tell me, unfortunately, there's nobody worth talking about at the moment at OHSU. That may change before too long, but right now, OHSU is totally depleted when it comes to clinical treatment.
Mm.
So you should let us know where you'd like a referral.
Well, I went to UCLA for main reason is I have friends and family there. Seattle's a hop, skip, and a jump from Boise Airport, and I, I just felt UCLA. It's more comfortable. My grandson, my daughter and grandson, and soon to be born granddaughter are down there, and so I kind of prefer a referral to SoCal. It could be Cedars, it could be UCLA, it could be anywhere. If you could give me, this group feels that they trust and would want their care being directed, then I'm all ears.
Okay, so Matthew Reddick, and we don't have anybody in the room right now who's with Dr. Reddick, I don't see, but we do have people currently who are seeing him, and they
How do
really
you
like him.
how do you spell the last name?
Retttig.
Got it.
Okay,
Perfect.
so he knows us, and if you're comfortable going down there, the guys all like him that
Is
I've
he at?
sent. I mean,
I'm sorry. Is he at UCLA or private practice or Cedars? Where?
UCLA.
Is it UCLA?
Yes, and I'll put his contact details in for you momentarily.
Okay.
But yes, and if you want to talk to people who have seen him, I've got a couple of people that I could connect you to, but I think that you'll be pretty happy with him. He's really sharp. He seems to be pretty compassionate. The guys relate to him nicely, so that would be my recommendation. Anybody else have any other ideas for Brian? So here we go. He
Dr.
just put
John
his.
has his hand up.
Go ahead, Dr. John. Dr. John or Dr. Jeff?
Well, both of us, I think. I just
Okay.
wanted to, while you're waiting for Dr. Reddick, I assume you're back on ADT. Is that true?
No, I'm not on anything right now. That's why I need to get circle up with an GUMO. Hold on a second. We're feeding the dogs. No, I'm not on ADT.
Well, if it happens to take a long time to get to Dr. Reddick, I guess that raises the question of should you be on ADT now in the meanwhile?
Yeah, well, there were those two trials that talked about combining ADT with a androgen receptor inhibitor and doing 9 months or intermittent. So that was suggested to me by a medical oncologist who has since closed her practice up here. So another reason I need to switch gears and get together with somebody who can. But I don't even. Here's a question. Retroperitoneal lymph nodes. That's probably a pretty bad place to try to spot radiate, I would imagine. Or is that possible?
Don't know. But again, there's some really good people down there. The doctor that we would recommend you talk to is Dr. Kishan, Kishan, at UCLA, and
Because he's an
we would
RO.
suggest that you combine Dr. Kishan and Dr. Reddick. Kishan is a radiation oncologist. He's one of the best in the country. He's got the
Got it.
most up-to-date equipment, and if anybody can get to those lymph nodes, he's going to be able to do it. Okay. So, and you might even want to see who you can get an appointment with first. Maybe you can get an appointment with them on the same day. We just had recently a guy who's seen both of them, and he was able to coordinate them very easily. But I put Redig's uh, link in the chat window for you, and let me give you Kishan's link. Um, KISHAN. Here we go. Okay, so Kishan's link is there. Okay, so that would be, and I do agree with Dr. John, especially given the level of your PSA, that probably sooner rather than later. And if we would suggest you talk to your doctors about Orgovix, and then they can add a second line if they want to add a second line. Do you have any comorbidities? Is your heart good, or do you have any heart CVD issues?
No issues. I mean, I just did a full nuke med study, cardiac. I worked cardiac for over 30 years. I'm still working locum right now. And my cardiac is fine. My renal function's normal. Liver function's normal. I mean, I have no comorbidities, no diabetes, nothing.
Okay, so are you telling us that you're a doc?
No. I can tell you what I am. But you'd have to Google it. Let's just put it simple as I'm the guy who runs a heart-lung machine during OP
I know
surgery.
exactly what you are. I know exactly what you are, because
Let's hear
we've
it.
had and I've just lost it, but we have somebody. Susan LaHaye's son does it.
Yep.
You are a
It's the ADT talking, Rick.
yes. It'll come back to me in a second, but yes, I know exactly what you do. Exactly.
Okay.
We have a we have some. I have somebody who's very close. I've got to look it up, and then I'll tell you in a second. But okay, so you
Yeah,
are
that's
in
okay.
the medical field, yeah.
I'm gonna be fully retired sometime between now and the end of 2025. That's my
Okay,
goal.
okay. Dr. Jeff, you had your hand up, so I can look up and see what those heart lung guys are called, because it's just gone from my mind all of a sudden. Go
Yeah,
ahead, Dr. Jeff.
yeah, I think Dr. John said what I would say. If I was in your shoes, I would be on two drugs as fast as I can. With a rising PSA, with Mets in your nodes, um, I would want to shut the cancer off now, and not delay and wait, but get someone to get you on at least in Orgovix, or if you like Eligard, plus something like abiraterone, um, quickly.
Thanks for that. Yeah, I think that's pretty much how I see things moving.
Hey, Rick.
Perfusionist. I got there just
Perfusionist.
before you did,
How do you
John,
guys
and
get a
and
perfusion?
and I
Good.
and I because Susan LaHaye's son just finished qualifying as a perfusionist. And then we also know somebody else who has somebody who's in the perfusion business. So
Hmm.
we know what you do. Yes. So I mean, I don't know if there's much else we can tell you, but I think there's some real urgency. I mean, I hate to think what your PSA is doing, and the fact that it's only showing up in the lymph nodes is a good thing right now.
Yeah.
I think I might, for good order's sake, discuss getting a FDG PET, just in case there is anything showing up that is not expressing PSMA.
Yeah, I
Um,
did one of those. Sorry, Rick. I did a FDG before, and that was also negative. And I was going to do the Axiom as my third scan, and that's when Ryder said, I just don't believe that you didn't have the membrane antigen. I want to check one more time. And I said, fine. And this time I'm coming to you. So that's how we found it. And by the way, they had 2 rooms. And when they were giving me IV contrast, oral contrast, and the gallium, I asked, hey, how new are the machines? And they go, well, we have 2 rooms, 2 machines. I said, well, which one am I getting? And he goes, you're getting the one with the newest machine in it. So,
Good.
maybe just blind luck and, you know, serendipitously find something, which I'm happy about because I know something's there.
Okay. Listen,
Appreciate you guys.
we've got 3 new men, so we got to keep moving. Keep coming back to us. We'll make sure you're there. We do a lot of good stuff. We also have a great session called Men Speaking Freely that Dr. John will be moderating on Thursday. I think that it might be a session you'd enjoy. We talk about everything and anything except the cancer and except the treatment, but anything else goes, like why you live in Eagle, Idaho. Right, Jimmy?
Hey, now come on now. And let me throw in, Brian, make sure to say hi to Ruby Creek for me and Stanley. And, you're very, very close to where I went to high school and lived with my dad in the Highlands of Boise when it was just a tiny thing. And so you just really are right up the creek, down the creek, over the so whatever. You're very close to where I lived for many years. And it's really great to meet you.
It's really great to meet you, Jimmy. And I am on 4.5 acres and flood irrigation. It's a little hobby farm I got going on here with sheep and chickens. And, I'm having a blast, having the best time of my life.
You hear that, Rick?
I do. I got you, Jimmy.
We got some mutton for you, Rick.
Unfortunately, I don't eat meat, but otherwise I'd love it. I have Welsh blood in me, man. I know all about mutton. Well, I know about sheep. I don't know about mutton. So,
appreciate meeting all you guys.
Okay. I'm going to move on, and now you've got the lay of the game. So, Henry, would you like to come up this week, or would you rather wait? It's your call, man.
Yeah, I'll go through it now that I know that I was jotting down some notes as Brian was going through the questions. I am not a medical person at all, so I'm not sure.
Okay.
But go ahead. I'll take your questions. I'm all ready.
Okay. And Henry, you got to do me a favor. You got to put the spelling of your last name in the chat window, and you also send me your email, because otherwise I'm gonna really hash it up. How old are you?
I am now 56.
Okay. And we got a group for you, a special group for you too. We've got an under 60s group, and I'll give you more information. But that doesn't meet till next week, and you'll see it in next week's reminder. And
Great.
where do you live?
I live in Mahopac, New York, which is about an hour north of Manhattan.
Okay. I don't know. I'm pretty good, but I don't know that. We've got Len on here who lives about an hour north, but I don't think. Is it near you, Len?
Oh, he's about a good half hour north of me. I think Mahopac is more than just an hour from Manhattan. It's probably more like an hour and 20 minutes at least.
Okay.
Beautiful area, Lake Mahopac.
I went to sleepaway camp in Lake Mahopac.
That's right.
Okay.
So it's a very old community.
Okay. All right, Dr. Jeff, Dr. Jack, we're all in good shape here. And when were you first diagnosed, Henry?
I was diagnosed in January of 23.
Okay. What was your Gleason and your PSA?
Well, I had no Gleason because I took myself to the ER because I thought I had appendicitis.
Yeah.
When they did the scans, they said I didn't have appendicitis. and they said I had something going on with my lymph nodes. So at that point, I was referred to an oncologist.
Okay. What was your PSA level?
The PSA was 359.
Okay. And they have not, and I understand why they didn't do any subsequent biopsies, so we really don't have a measure on your Gleason at this point. Is that right?
They did not biopsy my prostate. I've never had a DRE. I had my lymph nodes biopsied, and that's where they found the prostate cancer. So my abdominal lymph nodes, I had a biopsy on that.
Okay.
So I am stage 4. I have Mets to my lymph nodes, my L5, my sacrum, my left hip. Well, I did have it. I had a PSMA recently that shows no sign of metastatic disease.
Okay, well we'll get there in a minute. So where did you seek treatment, Henry?
I'm going to Phelps Hospital in Tarrytown, New York. That's where I went to the ER, and they have I'm very comfortable with the cancer program they have there. I also got a second opinion from MSK in White Plains.
From what? From
Memorial Sloan Kettering.
Right. From a urologist, a radiation oncologist, or a medical oncologist?
A medical oncologist.
And who was that? Do you remember the name?
I believe his name is Dr. Lee.
Okay. And the person at Phelps that you're working with, are they do they specialize in prostate and genitourinary diseases?
No.
Okay. Now, so you've done some scans. You said it was a PSMA scan that you did that saw the lymph nodes?
I did. No. Initially, it was a CAT scan in January of 23 that noticed my lymph nodes had a problem.
What type of CAT scan? Was that an FDG PET, or you don't know?
I do not know. It was just done in the ER, so I'm not sure.
Okay. And have you had a PSMA scan since?
I had a PSMA scan in, I believe it was April this year, April of 24.
And is that what saw the sacrum and the left hip, or not?
No, I had a regular PET scan when I was first diagnosed in January of 23. I just had a regular PET scan. Okay. That's what found the Mets.
And the PSMA scan was all clear, you said, the one you just did?
Surprisingly, yes. The PSMA scan from April came back and said no signs of metastatic disease.
So what sort of treatment did they put you on?
In March of 23, I had 5 rounds of radiation. I don't know what type, quite honestly. It was only 5 sessions for my hip and my back. And then I was put on abiraterone and prednisone and Lupron.
And are you still on that?
That was discontinued in May. I am currently on intermittent ADT. My PSA had dropped to undetectable as of November of 23.
Okay.
So my doctor and I discussed it, and I decided to go with intermittent ADT. So I'm on a break right now.
Okay, that's good. Has your doctor discussed with you debulking the primary?
No, we have not talked about that.
So that's a discussion that needs to be had. But I'm not sure that your general med onc is going to be up on that. But the consensus now amongst genitourinary medical oncologists is, especially in a situation like yours with a young man, is that they do radiate the primary. Sometimes they will also radiate across the lymph nodes. It really all depends. But they really advise radiating the primary, which can be done with SBRT, with high dose brachy. But this, one of the reasons why we strongly in this group recommend involving a genitourinary medical oncologist is because the general medical oncologist, they don't keep up with what's going on. So if you were at MSKCC right now, the likelihood is that they would be discussing with you radiating the primary, because they feel that
That could be
deters the spread.
that could be a serious benefit, it sounds like.
Right, and I'll let you. And there are people who have done it in the group, so we'll do that in a minute. Now, have you done any testing, mutation testing, either germline or somatic?
I did one of them. I don't know which one it was. There was nothing useful in it.
So this is another reason why. So the guidelines right now for prostate cancer, issued by all three, AUA, ASCO, and NCCN, all recommend that you have a somatic test.
How do you spell that? Somatic?
SOMATIC, somatic genomic testing.
Thank you.
And your doc should be on top of that, and they should have sent away either a blood sample, although your PSA might not warrant it at this point, or it's a toughie, or the biopsy that was of the lymph nodes that was taken. But the reason we do it is to see if you are suitable for any specific treatment. In other words, in prostate cancer today, one size does not fit all. And whilst the abiraterone and the LHRH were great, what we're trying to do is get you the best and the longest remission that we can find. And in order for us to do that, we need to know a little bit about the type of cancer that you have and how it breaks down. And that hasn't been done, and it should be done.
I'm thinking that it might have he might have done it back when I was first diagnosed. I'm gonna go back and look through my medical records to see if he put any notes in there about that.
Okay, well, it sounds like they did a germline test, which is just can be done from a mouth swab or a blood.
I did that. I did that myself, actually.
Okay, and that came back negative. But the
Correct.
issue is whether they did a somatic next generation sequencing, because those are the mutations you make yourself, and in addition, those can change over time. So however you tested before you started treatment may not be the same as you test today, because the cancer's smart and it adjusts and it moves around, and mutations you have today may be different from the mutations that might have been seen 2 years ago.
Okay. Sounds
Okay.
good.
So I'm going to, do you have any questions for the guys?
I'm good for right now. Thank you. I got a whole page of notes now.
Okay, so I'm going to open it up to you gents to talk a little bit about the type of doctor that Henry needs, and also debulking and anything else you want to talk about. So who is interested in speaking? Anybody? Len,
Yeah.
please kick off.
Henry, I need a little clarification on what type of scan did they initially do when they discovered the metastases in lymph nodes and bone, and when was that?
In January of 23, I had a biopsy of my abdominal lymph nodes, and that's where they got the sample and said it was prostate cancer. And then around the same time, I also had a regular PET scan, and that's what showed the mets in the bones.
You said a regular PET scan. Was that PSMA or?
It was not PSMA.
Okay. Sodium fluoride, maybe?
I would have to go and look at my notes again. I'm not the most medical person.
All right. So they discovered these metastases. They put you on what we call doublet hormone therapy. And by November of 23, you were undetectable. Did I get that right?
That is correct.
And then when did you begin intermittent ADT?
So my last Lupron shot was actually in, I thought I wrote it down here. In February of 24 was my last Lupron shot. And then 3 months later, when I went to go for my regular quarterly checkup, he decided to not give me any more Lupron. At that point, he took me off of the abiraterone. So that was at the end of May.
Okay, so just not quite 18 months like he originally told you, but pretty close, I guess.
Right.
And then you had the PSMA scan, the second scan that showed
second scan was a PSMA PET scan. That was in March, and that's the one that showed no signs of disease.
Yeah. I agree with Rick that you probably should have the primary treated with either radiation or surgery, preferably radiation.
Yeah, I would rather have the radiation, I think, than the surgery.
Sure. And also, it would be nice to know what your Gleason score is, because that tells us a lot about just how aggressive or non-aggressive your cancer is. It's likely, an 8, 9, or probably not a 10, but being that you had the mets to lymph nodes and bone, it's just,
they spared me. They spared me the pleasure of the procedure, I guess.
I mean, you have the tissue to, that from the biopsy already. So,
well, no, he doesn't.
Dealing with.
He doesn't have the tissue from the biopsy. There never was a biopsy.
The biopsy was
of the lymph nodes.
It was right of the abdominal lymph nodes.
Yeah. Well, I mean, you're doing great. You responded well to the hormone therapy. Just how often are you getting PSA checks now?
I asked him to do it every month for now. So
okay,
it's been
good.
Monthly. Yeah.
It's good.
Yeah, very good.
Yeah, that's good. Okay. Anyone else want to contribute to this discussion? Dr. Jeff, I'm thinking about you and your experience in finding the right doctor.
Took a while, but with help from here, pushing, I wound up, as you know, at MSK. And MSK isn't that bad a drive from Mayopac.
You muted, Henry.
Yes, I just realized. MSK actually has an office now on Westchester Avenue in White Plains.
Yes, correct.
So that's a great drive for me. It's 25 minutes.
Right.
That's where I went for my second opinion also.
Yeah. The problem is that, and Len can comment on this. As far as the GU medical oncologists are concerned, they don't have the A team there. And that's the problem. And once you see somebody, you cannot, it's very, very hard to switch. Really hard to switch. And I think, is there any, Len, is there a good GU med onc in Westchester or not?
Yeah, not that I'm aware of, Rick. He can get good radiation oncologists in
Yes.
Westchester,
Yeah.
but for good med oncs, I think he'd have to go to Manhattan.
Yeah. Yeah, I mean, if it were me, I wouldn't be seeking a second opinion from a GU medical oncologist. I don't even know if Lee is a specialist. He may be a general medical oncologist. I honestly don't know. One of the guys will look him up and tell us shortly. But I think it's really important in planning your treatment. You really need as comfortable as you are. There's a couple of things that really are unconventional. One is that they've never done, with a metastatic man, they've never done a next generation sequencing. That is not, that's against the guidelines. Secondly, that he took you off prior to 18 months. That's against the guidelines. People do less, but usually because they need to or they have to, but to invite your patient to stop prior to 18 months is unusual. And if you can bear with it, sometimes even longer, brings better results. So these are all things where we'd really like you to be seeing a really solid, well-known genitourinary medical oncologist, either at NYU or at Weill Cornell or at Memorial Sloan Kettering or Presbyterian. But it's just so important. I cannot tell you how important it is to have somebody like that on your team, Henry.
Okay, I'll definitely look into it. You're pointing me in a new direction, so I appreciate that. Thank you.
And keep coming back to us, keep running names past us. And you know, it's we're here for you because we want to see you get the best. The other thing is this under 60s group might be a very good group for you. That's only for gents under 60 and who are stage 3 and stage 4. We usually have a bunch of those guys in today, but they must be playing with their kids because it's Labor Day weekend. So
yeah, I'll look for that meeting. I'll jump in there.
Yeah, and they'll give you some good advice. But I just want to see you strengthen up that team of yours, because that's what's concerning me the most right now. And it doesn't mean that what they've done is wrong. We're not saying that it was bad, but this team isn't strong enough. You know, God forbid the cancer comes back, and the you know, it's quite possible it will in your situation. You gotta have the A team, and not somebody who is dabbles in prostate cancer, and which your doc sounds like he does, because he's not doing all the things we would hope he was doing. So that's all I can say. I just want to tell Alan from New Jersey, we're not having any problems in this meeting at all. So this is all either your connection or but one thing you might want to do is call GoTo and see if they can help you, but I don't think it's the meeting. So you know, you may have, as Jim Marshall says, you may have Jim Marshall, could you put the 877 number in for the go-to help so he can call go-to?
I don't have it, Rick.
It's in the it's in the reminder. Okay. Well,
I'm not
somebody
signed on
please,
to it, so.
somebody please, if you can put it in. Okay. Anything else for Henry before we go on to our last man? And we only have two people that need time, so don't sweat about us getting to you. We will get to you, and one of them is Alan, and he can't hear us anyway. But hopefully by the time we get to Alan, we'll be okay. Alan, the phone number is in the reminder. Please check the reminder. Go to the reminder, and you'll find everything in there. I would normally put it in if I wasn't moderating, but I can't keep that many
Just came
balls in
back.
the air.
Audio just came back. Thank you.
Okay.
Is it my turn?
No, it's not your turn. Okay, we've got another new man to take, and I do suggest you might want to talk to GoTo and see if they can straighten you out. The next gentleman that we're going to go to right now is the last new man, Bob Pethtal. Hello, Bob.
Rick, thanks for having me.
It's a pleasure. It's what we do. How old are you, Bob?
75.
Okay. And I'm assuming you probably, well, I shouldn't assume anything. Where do you live?
In Nokesville, Virginia.
Okay. Nokesville, VA. That's probably how you found, and you're probably, well, you may not be. Are you a vet?
Yes, I am.
Okay. So that's how you found, I didn't ask Henry. Henry, are you a vet? No. Okay. All right. The reason we asked that question is, as Bob well knows, we have a fantastic vets group that will start to meet twice a month as of tomorrow night, which is in the command of Captain Jim. And if you know any vets, please send them to that group, because it is not disease specific. It's all about getting the best health benefits and the best navigation. And you can have you might even be going to talk to him about your dentist. It doesn't matter. We just help you find the right way to do it and make sure you get the most amount of money you should be getting. When were you diagnosed, Mr. Pethtal?
Well, originally, I was treated back in 2013-14 with a cryoablation. And it took my PSA down to 0, so everything was fine until...
Hold on. Let me do it. Let me go through my questions. So then we can, okay? So you were originally diagnosed in 2013-14. And what was your Gleason score at that time?
At that time, I don't remember. I'm sorry.
Okay, so you don't know your original Gleason score?
It's somewhere in my records. I probably could round that up if I had to.
Okay, well, it could be important. What was your PSA when you first got diagnosed?
Years ago, it got up to sometime 8, 8.5, 8.5.
Okay. And where did you go for treatment back when you went for your cryoablation?
Johns Hopkins.
Okay. And this cryoablation, was it focal or was it to the whole gland?
The whole gland.
Okay. And so was it who did that? Was it a urologist or was it a radiation oncologist?
No, I really don't know what he was. They sent me to him. I went to a a meeting where there was a team of doctors, and he was the one that was missing that Saturday morning. His name is Dr. Leslie Ross. He has since moved on to Houston from Johns Hopkins.
ROSS?
Yes, sir.
Okay. So he treated you. He radiated the whole gland. Was this through the VA, or was this you going directly to Hopkins?
Directly to Hopkins.
Directly to Hopkins. Okay. And what made you decide to do the cryoablation at that time?
It was a very busy time for me career-wise. I had a lot of things going personal-wise, and it was the fastest recovery time. I'll be honest. That's how I
Okay.
chose it.
Okay. No, I mean it's good enough reason. Good enough reason. And what happened after you had the cryoablation in 2014?
Well, as I said, the PSAs went all the way down to 0, and on my annual checkups, we were carefully watched that since then, and they've been creeping up ever since. It stayed under 4 for a couple of years, then it snuck over to 5 point something. My last check was in June at 10.6.
Okay. And who is watching this? Do you have a somebody who's a genitourinary doc involved, or is it your PCP that's monitoring you?
No, I got urinary people from SHAR Cancer Institute.
Okay, so
For
and
radiation, it's Dr. Kevin Cho,
okay,
and they've
so
recommended.
is Kevin Show the guy that's like leading the show, as so to speak?
Well, there's a Dr. Joshua Allen that's going to be
Yeah,
doing.
we know him.
Okay, hormonal therapy is going to be conducted by him. So he.
Okay, so you're seeing Josh Allen, and as your MO, and have they done a PSMA scan?
No, that's scheduled for next Friday.
Okay, well
Thanks
that's
to
going
Captain
to
Jim.
yeah, well that's going to tell us a heck of a lot more. So right now you've got a PSA somewhere. It was 10.6 in June, the most recent PSA, or have they done one since?
No, that's the last one I had.
Again, they really should be doing them at least pretty much every 3 months. So you ought to be having another one this week.
Well, I can get it. Yeah.
Well, I think it's important because you want to know how quickly this disease is moving. And this is why it's important that we know what your original Gleason was, because that's going to be an indicator. So they may have that, and they may be making decisions based on that, but it would be good for you to know. Ask them, what was my original Gleason?
Yeah.
And it should be in your records. And you're talking to Dr. Allen, and Dr. Allen right now, before the PSMA, has he given you any treatment suggestions, or is he just saying that it's all dependent on the PSMA?
Yeah, they didn't recommend the PSMA. As I said, Captain Jim suggested I look into that, and of course they jumped all over it when I asked them about it. So it's scheduled for this Friday, and then I'll see Dr. Allen.
Have you seen Dr. Allen yet?
Yes, I have.
And what treatment was he recommending prior to the PSMA?
Well, he didn't really recommend any because I had seen him. I was given an option between radiation and hormonal therapy, and that being option 1 and option 2 being surgery. And I wanted to talk to a surgeon just to dig deeper and find out what I needed to know about making that decision. And that's where I was when Dr. Allen said he knew of a surgeon. One surgeon in the clinic suggested that because of my cryo and the MRI showed some scar tissue, that he didn't recommend it. But they knew that I was looking for an option, and I already cast that off. I wrote it off, and then talking to Dr. Allen, I told him why I'm now leaning heavily toward the radiation and hormone therapy. And he said, I just talked to our chief urology surgeon today, and she was telling me that she's had great success in prostatectomies, even though there's a cryo treatment in the history of 10 years ago. So I took all the information. I had got an appointment with her and took all that information and concluded that I wanted the radiation side of treatment.
Not only that, they have no business. They have no business, in my view, discussing radiation with a 75-year-old man. I mean, that to me is, it's just out of line. I mean, they do it occasionally, but a
You mean
75-year-old.
prostatectomy? You mean prostatectomy, Rick?
Yeah.
Yes. So I'm sorry that they have no business talking about surgery. Thank you for the correction, Dr. John.
Okay.
They have no
Now I
business
understand
talking about surgery with you, with a 75-year-old man. It's crazy. I mean, you know what? I don't get it.
Well, it was total naive, and it came up originally because I said I'd like to do away with it once and for all. Dr. Ross told me in 2014, he said, now look, we're going to do this, but there's no guarantee you're not going to have it back someday. And I said, I understand that. And he said, 8-10 years, you may be looking at it come roaring back. So he was pretty much on spot with that. But again, I wanted to get through it at the time and settle down and, healthy as a horse.
Yeah. No, I get it. But surgery to me, for somebody of the age of 75, is a non-starter. So, well, I mean, Alan's pretty good, except why he didn't do a PSMA. I don't quite know what they think they're going to radiate. I suspect I know, but they need to know what they're going to be radiating and where exactly this is. And I'm not sure how they were going to figure that out without the PSMA. So just a bunch of questions here. I'm going to throw it out to the guys to, let me ask you, did they, have they done any genetic testing?
Yeah.
They did. And what was the result of that?
Well, if I'm reading it right, if I got the right line off the report that I got, I'm an intermediate risk.
No, they need.
And the decipher is 59.59.
Right. No, that's a different type of genetic test, and I don't know enough. 0.59 is I know is relatively high, but that's sort of a treatment. That's a test that's usually done for somebody that hasn't had any treatment yet, and not on a recurrence. But what I'm asking about is, do they test to see if you have any inherited cancers?
Well,
Any inherited mutations?
They ask about family history. And I've got a couple of sisters, a grandmother, and a daughter. That's all been affected.
And what's the cancer in there?
The daughter, she lost a breast, and they took them both so that they could be safe with that.
Right.
One sister was also a breast and female organs. I'm not remembering the name of what was the female problem with Linda, but
so here's the thing. Have they tested you to see if you carry any inherited mutations?
is that by a blood test or something like that? I might
It
recognize.
can either be a blood test or a mouth swab.
Oh, no.
All right, so I'm going to put, again, it's kind of important because if you've got breast cancer in the family, and what about your mother and your grandparents? Did they have cancer? Did your mother or your grandparents have cancer? Do you know?
I think Henry, the session's frozen.
It looks
Yeah.
frozen.
Looks like having trouble.
Okay, well, Jim, you follow up with him, and let's try and find out, and give him the link to our promise link.
I
Okay,
will.
I'll put our promise link in here. Promise. I'll put our promise link in here, but it could well be that he's carrying a mutation there, and that's where it's coming through the family. So obviously we're concerned about that. Here's of course, if any of you on this call have not done germline testing, you can get a free germline test through Hopkins or University of Washington at this link, and I'm putting it in right now for everybody. And they just send it to you. They just send it to you through the mail, and you return it. And then if you need they'll give you a genetic counselor. I don't know if Bob can hear us.
I think he's gone.
Okay, well, that's what Henry did. Henry did the old promise test. Good for you, Henry. Pleased to see that. That's what I thought when you said 32, because that's through color.
He's still here.
All right. I tell you what, we'll suspend Mr. Pethtal until he returns and have a conversation, continue the conversation, and we'll go to the two people who have questions. And one of them is Alan. So Alan, please go ahead.
Yes, good evening. One question: has anyone in the group been on Xtandi monotherapy long term, and did it eventually fail to work? Because in light of recent reports that extended use of Xtandi as well as abiraterone may push the cancer to morph into neuroendocrine cancer in response to the treatment.
So that's not new news. We've touted that probably for 10 years. We know it has nothing to do with monotherapy or doublet therapy. If you stay on one of these second line antiandrogens for an extended period of time, you run the risk of it morphing. Dennis Correa, who is on the call today, will tell you that. He got off of it and he had a holiday for a while. Right, Dennis? Oh, here he comes.
Yeah, that is true. I've been through a number of these things. I did Abby for quite a while, the abiraterone. Prednisone, the same concern. I've just coming off another intermission period, and I'm going back with the darolutamide, Nubeqa.
Right, but you have to keep the cancer on its toes, and one way you do that is not by staying with any one of these agents for too long. 5 years is too long a period of time, so it doesn't matter whether you're starting it with Lupron or whether you're starting it with monotherapy. You need to either take a break, which is fine, go back on it, switch to a different agent, but you've got to switch around.
How long of a time period are we talking?
About what? How long do you can stay on it?
Yes, before you need to switch
You
or
know,
stop.
again, we can't give you medical advice, but we can only tell you what we've seen. Where we've had guys who have been on a single, on the same second line anti-androgen for 4 or 5 years, they haven't been able to find a treatment when they've come off of it. So we will generally tell people after they've been on it for maybe 3+ years, talk to your doc about taking a break or talk to your doc about switching the agent. I don't think we really know because we don't know enough about the biology of how the cancer gets smart and how the cancer switches. But we do just know that it does. And this isn't anything new. This goes back a long, long time. This goes back years. Um, Back in the mid 2010s, we were talking about the cancer morphing. So whatever you're reading right now is maybe new to you, but it's not new to us, and it's not new to a genitourinary medical oncologist who should be well aware of that.
I did raise that question about switching to my medical oncologist, and he's against it. He says that basically, you shouldn't switch because then there'd be nothing left to use. I don't know if that made any sense.
No, it didn't. You raised the question of switch. How long have you been on? I mean, as I recall, you have this situation where your disease is in the gland and it keeps coming back, but you're a 4+5 and they can't see it anywhere else. Is that right?
That's correct.
And who's your main GU medical oncologist right now?
Dan Geinesman.
Okay, and how long have you been on enzalutamide?
It's 6 months now.
Okay, so there's no reason to switch. That's what Dr. Gainesman's saying to you. Why would you want to switch after 6 months?
Well, he's the one saying that I should stop and look for local therapy.
Okay, so
I asked him,
what's wrong?
I asked him, what about switching to darolutamide? And he says, no, that's a bad idea. Because I'm having a lot of the issues with Xtandi, like the memory lapses, confusion. And he says,
Okay, well
no,
that's a whole different story. So if you want to switch, if you're talking to him about you worried about it, are you telling him you're worried that it might morph?
I mentioned that to him, and he said,
Yeah, but you see, you drop a red herring in there. So then he's going to say to you, no, you're not going to morph. Now, if you go into him and you say to him, I'm having a hell of a time with the side effects, and I can't think straight, and I want to be on darolutamide because of that, then you may have a chance of getting him to do something. But when you mix things up, you see, a little knowledge is a dangerous thing, and people go in and they Google and they find this, that, and the other, and then they go in. And Gainesman's a smart dude, and he doesn't want to know because you're feeding him a crock about with the morphing after 6 months. But if you go in and tell him, look, I can't deal with this because of the side effects, then maybe you get a different response. Larry Fish, you've had your hand up for a while.
Hi, Rick and everybody. So this whole theory about switching, how long to wait before you talk about switching, and which drug do you switch from, which drug do you switch to, is this theoretical or is this research based and it's advantageous to switch and that prolongs the time for the morphing, or is it theoretical? And if it's not theoretical, if it's factual, which is the one that is most likely to last the longest before you have to switch, or are these just open? There's not enough research.
Well, it's based, we know the cancer morphs. That is totally down to clinical evidence.
Yes.
Going back really to Eric Small and Rahul Agarwal were amongst the first, not the first, but they were amongst the first to see it. Now, why does it switch? We know it switches because it becomes resistant to other disease. Has it been studied how long you can stay on? I don't know. I've never researched that, but I can tell you that in men that we know, Richard Foodie, God rest his soul, Rob Barniskis, who this room is named after, God rest his soul, and others, we have seen Jake Hannum on enzalutamide. When these guys stayed on and they didn't get off, and when they did, and they needed another treatment, nothing worked. I mean,
Well, I think that's a
Foodie lasted maybe a year and a half. Rob a little bit less. Jake about the same. And the cancer becomes so smart, we don't know what to do with it. Now, was Foodie pre Pluvicto? I can't remember.
Yeah, he was pre-Pluvicto. Yes,
Yeah.
but he was on enzalutamide for, I don't know, 4 or 5 years, and eventually he developed neuroendocrine.
Yeah, that's right. Yeah.
Yeah.
So I know where you're going with this, Larry, and there may be an answer. Ask Audio. She would know where the research.
I'm moving into like between 3 and 4 years on darolutamide. And the question, what do you think about the idea of maybe switching it up for a while or holiday? And she said, well, people, she understands that idea. Says, but there's no evidence from her point of view that switching leads to anything conclusive because there hasn't been enough research on what happens when you switch, how long do you feel longer morphing, and how long do you feel longer for, and which is the best one to switch from and through, and that as long as your PSA is undetectable or nearly undetectable, may not be the time to experiment with switching.
Okay, well,
So
forget the
I don't,
switching. Forget the switching. Take a break,
yeah,
which is what Dennis did. Forget the switching. You don't
yeah.
have to switch, but if you take a break, it's as good as switching.
But at
Well,
6 months, it's a whole different story.
Oh, hold
Mm.
on a second, because I agree with you, but all right, we'll come back to you, Larry.
that's
John's
okay.
right. We
It's a
should
long
come back to you because we'll have time, and that's a different issue. And we're getting sidetracked off of. And so John's 100% right. I stand down. John's right. 6 months. There's nothing to discuss.
I agree.
Alan.
Yeah.
When I was on double therapy and my abiraterone had become intolerable, and I'd only been on ADT for 8 or 9 months, then they switched me from Abby to darolutamide because of intolerability of abiraterone and because not insufficient time had gone by to even consider a break.
Yeah.
How
And
long
I
did
think
they say you should be on it before you consider taking a break?
2 years in my case.
Wow. Dinah's been saying 6 months.
Yeah, but you have a different situation, Alan.
6 months for your total ADT treatment only?
Yes.
Yeah, but
Oh, okay. So that's different from my situation.
yeah, the situation is different, Alan.
Yeah.
You don't present your situation fairly every time. You have 4+5 disease. We can't find any evidence of it in the whole of your body, and it's come back in the gland. And that's a very different situation. It's a one-off, strange situation, and you can't compare yourself to any of the guys in this room because you're not, as far as we can tell, you're not metastatic. Nothing shows up on a PSMA scan, correct?
That's correct so far.
So you're different to Dr. John, who was metastatic, and others who are metastatic. We suspect you might be metastatic. If it were me, if it were me and I was electing treatment, I know exactly what I would do. I'd go on ADT and a second line anti-androgen, and I'd gut it out for 18 months. That's what I do. But if you're complaining about you can't tolerate it, that's why Gainesman's saying come off of it. He's giving you good advice. But if you really want to get rid of this stuff and get it and be done with it, you need an extended period, because with a 4+5, it could be anywhere in your body, and you've got to try and kill it and get rid of it. Richard Fisk.
Yes, I started out on 1,000 milligram Abby and couldn't handle it. Couldn't handle the side effects. Went to 750, couldn't handle that, and I've been on 500. PSA is 0.014, undetectable, and I'm at month 22 of 24.
Right. And that, frankly, is what you got to do, Alan. We're happy to have you, but you each time you come back, and it's like you're querying what's going on. Well, your situation is unusual, and the solution for somebody like you, we don't really know, because we don't really see the disease coming back in the gland after the gland has been radiated. But in your case, it has, very unusual. But you just got to go on extended ADT and try and nail it. I spoke to Dr. Munster about the trial that she's running, but she feels she doesn't know the doses. They don't have enough. They don't know how to dose this right now. That's what they're working on. And she would not be willing to do an N=1 and insert a capsule of enzalutamide right into the gland. But, you can raise it with Gainesman and tell him that if he wants to talk to Dr. Munster, I'm happy to put him in touch. He knows us well. I'm happy to put him in touch. And that would be basically enzalutamide local therapy in the gland, and they have the ability to do that right now. But he'd have to convince her that this is what they need to do. But this is really unusual stuff. This is all N=1 stuff.
Oh, since there's no evidence on metastatic, am I actually in the wrong group?
Well, you could be. But, no, I would say you're not in the wrong group, because this is the group for high risk, and you're certainly high risk. Because you have 4+5, you have a 4+5. But the other group isn't going to know. The other group isn't going to know anywhere near as much. But you're welcome to attend it. Anybody can attend any group. You can attend the low intermediate next Monday. But I don't know what they're going to tell you. I don't know what you want to hear. What would you like to hear?
Just want to hear some of my options. What to do at this point, because
okay, so your options would be to probably to go on long-term hormone therapy, 18 months minimum, which I think doublet, ADT plus a second-line anti-androgen. That would be one option for sure. I believe they've told you they can't radiate the gland again. Is that right?
No, they said they could, but other doctors I have talked to said that's a bad idea.
Okay, well, you've got to go with your main doc. Does Gainesman think you could radiate the gland?
He's pushing for that. He's also pushing for cryo as a local therapy.
So there's two more options, cryo or radiation. Who tells you not to radiate the gland?
I checked with another radiologist, local radiologist, and he feels that based on this is the partner of the guy who radiated me initially.
Okay,
He
even
said,
up, even up. Do you want to talk to a local radiation guy, or you want to talk to somebody at a center of excellence who's in consultation with a top GU medical oncologist? Whose opinion are you going to take? The local guy or a radiation oncologist at Fox Chase who's in consultation with Dr. Gainersman? Who are you going to listen to?
well, that's the reason I want to get as much information as I can from other people who may or may not have a similar situation.
Well, very few people are going to have a similar situation. I've never heard of the disease coming back at 4+5. Did you have you had it biopsied again? This new lesion that's showing up?
No, I suspect I'm going to ask for that if I
Okay, well,
follow his advice to stop it, because he feels that if we stop it, it's going to return pretty quick. So
okay,
then we would
well,
have a chance to biopsy it and then see what's going on.
so how big is the lesion right now?
The lesion is the last PSMA. This was after Orgovix, but before the extendee was about 1 centimeter in size on both lobes.
Okay, so it's big enough that they could biopsy it. If it were me, I'd go with Dr. Gainersman's advice. I'd radiate it, or I'd go with cryo. I can't tell you which, and come off the enzalutamide and radiate it and go with cryo.
Did you say come
Okay.
off? Yeah, okay. I'm sorry.
Well, he said didn't he say come off the enzalutamide,
Yes, he says
doctor?
stop the enzalutamide. He
Well,
expects
that's what I do.
the
That's
PSA
what I
will
do.
rise pretty quick,
But
and
that's what
then
I do. You got to make a decision to do something. You know, there you go. It's right there. Come off of it. Let them radiate it again if they say they can. If they can't radiate it, go after it with cryo. Get as much information about it as you can. Do a biopsy first. Send the sample away and get an NGS on it, next generation sequencing on it. And I want to go to Tom Cook, and then if we've got time to come back to Larry Fish. But does anybody have anything else they'd like to say to Alan? I think that's the best we can do, Alan, is
okay.
you've got a
Thanks,
good doc. And who's the radiation oncologist you're talking to?
Horowitz.
And no, I'm talking about at Fox Chase.
Horowitz.
Horowitz at
I
Fox
forget his
Chase.
first name. Horowitz.
Horowitz. Okay, well, I don't know him, but I would go with the advice from Fox Chase if it were me. Okay.
Okay, thanks.
Tom Cook, you had a
Yeah,
question.
yeah. I've was having trouble. Well, my PSA is still at 0 as of almost 3 months ago now. I've been having back issues and hip issues. Uh, talked to did some PT after my last visit. Then the back and hip seemed to be getting worse. My oncologist did it, put me in for a nuclear bone scan. But my questions is the only thing that comes back on there, 2 new areas of high tracer uptake are seen involving lower or right lower, likely 8th and 9th costochondral junctions. And I don't have any idea what that's telling me. I was
It's
hoping someone here.
your ribs, costochondral junction. That's your ribs.
Okay. So then it's just they're finding something in my ribs now, I guess. I go in next week. I'll see my oncologist and get my treatment next week. So I just, rather than sitting on this for another week, or I thought I'd ask you guys what you know about it. Um, so
So
that was
let's just back up one, okay?
okay.
And you're in Oregon, correct?
Yes.
Yep. So let's just back up. Let's just back up a little bit. You've got pain coming from your back and your hips, right?
Yeah. I
What doctor? What type of doctor are you seeing right now?
um uh the medical oncologist just she's
Okay.
and
And is that a local medical oncologist or is it somebody still at OHSU?
this is a local one. I went to from your recommendation, I went and saw Dr. Beer before he changed what he was doing, and he agreed with what she was doing and said he wouldn't. If I really wanted to change, he would have taken me, but he said there was nothing that everything she
Okay.
was doing looked good.
Yeah, did you ever debulk the primary?
No.
Okay. So, again, when we don't get into this and we don't put these questions before the doctors, sometimes they're not going to raise it. So the discussion, because I have a note that there should have been a discussion of debulking the primary. Now, has this doctor talked to you about a PSMA scan?
She was talking when my PSA when my PSA starts to rise again, that would be the first thing we'd go to.
And where's
And
your PSA right now?
it's less than 0.01.
And are you still on Zytiga and Zomed? Are you still on
Zoladex.
abiraterone and
Yeah.
Zoladex?
Yes.
So the problem is that is suppressing the PSA.
Mm-hmm.
But it doesn't necessarily mean that we won't see anything because you have a history and you're getting pain, so you're symptomatic.
Yeah.
So
Oh.
again, my discussion, and this is why, again, we really feel it's important to see a GU medical oncologist, because the general medical oncologist is going to say, oh, it doesn't have a PSA, so we're not going to see anything on the PSMA scan. But for a man who has a history of metastatic disease, that's not necessarily the case. And so it becomes a judgment call on whether they can justify it with the insurance, and there may be something there to see. And
Okay.
the local people, the general medical oncologists, they don't get that. So the only way we're going to ever see a PSA in your case is either if you become castrate resistant, or if they just go ahead and do it and they see something there. And it concerns me because how long have you been on the abiraterone now?
It'll be 5 years in January.
You need a break, man, as you just heard. You need a break off
Okay.
of that. And again, the local GU medonc isn't going to know that.
Okay.
We've got hands up. Dr. Jeff, go ahead.
So do I have it right? Your pain is in your back, your lower back, and your hips, and
Yeah.
the lesions are that you described are costochondral.
Yes.
Okay, so they're unrelated. I mean,
Mm-hmm.
where your ribs meet your breastbone, that's
Yeah.
where you're having the lesions. That's nowhere near your lower back and nowhere near your hips. So what they're finding in your ribs, if it's anything, isn't giving you the symptoms in your back and your hips,
Yeah.
which should be encouraging.
Yeah, well, I've got scoliosis, and when I was diagnosed, I had a fractured pelvic. They didn't want me doing a lot of exercises, and I've been losing muscle mass. I've gone into the exercise programs, but it hasn't, I'm not building muscle. I'm still losing it, and I'm thinking that I may have a compressed disc or something. So there's reasons that I could have the pain there.
Right.
And but that was what I put to her, and she said, let's get another bone scan, make sure we aren't finding anything.
Right.
And now it appears we may be finding something, since they found these two new areas since when I had my initial two bone scans that I've had before. So should I be asking for PSMA to see if it is the cancer spreading, or?
I mean, I certainly think that there's reason to raise it, but I think the first thing I would probably do if it were me is I would get off of the abiraterone and the Zoladex, take a treatment holiday, and then if my PSA rises, we can then do the PSMA. But after 4 or 5 years, I would come off of it and then see where that goes. That's what I would do. I mean, that's from my own experience, but that's not advice to you. But it's certainly something you should be discussing, and you should be discussing it with a GU med-onc, not a general med-onc, because we said in the earlier on, Tom. The problem is there's really nobody right now at OHSU. It's a real problem. It might get addressed very, very shortly, but right now there isn't anybody there. The only person you might be able to get an appointment with is Julie Graff. But
Okay.
I can't guarantee that's a problem. Buki's gone. Beer's gone. There is, what's her name? Alexandra, the Russian lady. She's still there. But she's not super experienced, but that would be anybody remember her name? Tom,
It's,
where?
it's
Yeah, Tom.
Sokolova, isn't it?
Yeah,
Sokolova.
Sokolova. Yeah, Thomas sees her. Is Thomas still with us, or did he leave? Thank you, Gary. Yeah, Sokolova is the person right is one person right now. Alexandra Sokolova. But I think you've
Okay.
got to have a discussion about taking a break, and then we'll that would give us a good. If we suddenly saw a huge rise in your PSA, we'd be able to see where it was. We'd know if where this was coming from. But after 4 or 5 years on abiraterone, again, you don't want the cancer to morph to become something different. And there's a. Are you having difficulty getting out of a chair?
No.
Okay.
I've
So hopefully it hasn't morphed. But I think that this is what you got to be doing. Give your body a break from the. Oh, Thomas is there. Are you there, Thomas?
Yes, I am. Yep,
You see Sokolova, don't you?
I do. The other name that you gave me over there when I started this discussion was Mark Garzato, and
Okay.
so I'm not sure about their qualifications. I haven't been seeing Dr. Sokolova often. She was off on medical leave, and she might have had a baby. So I'm just not sure of that. I have an appointment coming up, but my condition is kind of stable. So
Okay.
I sure wish I would hear you talking about some great people over there at OHSU. That would be nice.
Well, there may be a great person there within a short period of time, but I'm not at liberty to discuss that now. But
Well, that's
it's
good. It's
possible.
good to yeah, it's good to hear you say that.
Yeah. So
Yeah.
Tom, Tom Cook, that is, not Thomas. I just think that I think the first thing to do is to try and get a consult with a genitourinary medical oncologist and to talk to your doctor about taking a break is what I would be doing. Anybody else?
Rick?
Go ahead, Jim Marshall.
Yeah, Tom, anyway, I was on it for 5 years and anyway, took a break. Anyway, ADT will probably take close to probably 9 months to a year to recover, depending, but it's been interesting. It's been nice. And I'm on 2 years now on holiday.
Hmm. Okay, that sounds good, promising.
Rick, it's John. Can you hear me?
Yeah, go ahead.
I'm not really sure about this, but on paper, it seems like Sokolova is not all that inexperienced and probably would be a great idea since she hopefully is nearby and more accessible.
Yeah, yeah.
Okay.
I mean, I think she's sort of been practicing for about 2 or 3 years, John, from what I know.
Oh, that's all?
Yeah.
Okay.
I'm pretty sure she was previous to that. She was a fellow, and I think that's about right. Go ahead, Thomas.
Yeah, it says that she is accepting patients at this time.
Okay.
But yeah, I think Sokolova might be for where you are and what you can do. That might be your best bet, and to have the discussion also. I mean, if your local general medical oncologist doesn't want to consider taking you off right now, then definitely see Sokolova. But I would be wanting to add a GU med onto my team.
Okay.
Okay. Anybody else? We'll come back to Larry Fish, but anybody else want to say anything to Tom Cook before we flip back to Larry?
Let's see, Bob Pethtal is back.
Oh, Bob Pethtal's about. Okay, well let's deal with Larry, and then we'll go back to Pethtal. Larry, so it's sort of much the same thing. I mean, I just think we get very nervous when we see people on the same drug for a long period of time.
No, I understand. Sure.
And so, if Audio doesn't think switching, then come off the drug for a while. You'll feel better. See how you do. You're going to keep a close eye on it, and it throws the cancer off guard.
So you're thinking you're not recommending, but you're saying to consider taking a break at this time, even though I'm undetectable and not suffering too much.
Well, because you're undetectable. You don't want to take a break if you're not undetectable.
So now is the time I would take a break. But I understand, but I just don't know that there's any actual evidence that makes a difference.
Well, we have anecdotal evidence, and I think you need to do the research, but we strongly believe that you got to keep that cancer off guard. And so somebody like Jim Marshall comes off after 5 years. He's got 2 years holiday.
Yeah.
And when we see people who don't come off and their cancer starts to rise, we don't know how to treat them. So we have a few hands up here. Bob Pefto will get to you momentarily. Thomas, do you have something else you wanted to say, Thomas, or can I take your hand down?
You take the hand down.
Thank you. Okay,
Thank you.
so Jim Marshall, you still have your hand up.
Yes, there was a paper I got from Len detailing about the 30% chance for the neuroendocrine thing. Okay, and I read it and I decided to take the vacation. So there is a paper out there. I do have it. Okay, so it is available.
Jim,
Explaining.
was that the ARCHES trial, the post hoc analysis of ARCHES trial with Dr. Armstrong at Duke?
I'm not quite sure. I haven't read it in about 2 years because I read it and said it's about time to take a holiday, and I took it. So
Well, Rick, there was this post hoc analysis of the ARCHES trial, which was enzalutamide.
abiraterone too. It's
Yeah,
in there.
yeah, enzalutamide or abiraterone, and what happened? The 30% I think is coming from the fact that 30% of guys, after being on these drugs for a while, will have radiographic progression without PSA progression.
Right. Now I remember. Right.
Yeah. Now there was another study. I forget who is involved with that one at the moment, but they're the ones who first discovered. I think it was more like 20% of guys who were on abiraterone and enzalutamide for prolonged periods, 15 to 20% would develop neuroendocrine disease, whereas in the days before these drugs came on the market, the incidence of neuroendocrine was about 2%. So clearly these drugs were, extended use of these drugs was resulting in the cancer mutating to a less treatable or untreatable form.
Yeah, no. No, the question with that kind of study is that you don't have like earlier research showing uh, how long people are on drugs. I mean, how long people live before they started with the second level. I think like the statistics can be confusing when you start to think about like what is it exactly true that that's true that until the time we started to do that study they didn't see morphing. Is that because they didn't see morphing because morphing was wrong? I mean, it does lend itself to wanting to see more research specifically. I don't know if anybody else has a feeling about that. It's clear that staying on those drugs for cancer finds a way.
Yeah, we're not hearing you too clearly, Larry. I don't know, your microphone coming in and
Sorry,
out.
is that better if I move close to the mic?
No,
Much
that's
better,
much
yes,
better.
please.
But Larry, look, here's the thing.
Yeah, no, I understand what we're saying.
You can talk yourself out of anything and you can talk yourself into anything. But there is evidence out there that long-term use of these drugs lends itself to more neoendocrine small cell disease. Some guys may get the neoendocrine small cell in a much shorter time, like Herb, God rest his soul.
No.
But we know that people, the men that we know who have been on long-term use have all had the same issue. When they came off that drug, and because their PSA started to rise, we couldn't find another thing that would treat them. So
Yeah.
just from our own anecdotal evidence, and I'm sure if you talk to Karen Audio and said to her, your people who were on a single agent or a doublet agent for 5 years, how did you treat them? She'll, I bet dollars to donuts. She said, well, we didn't have much we could do after that.
No,
Well,
they
why
can
leave,
try
why leave them on?
whack-a-mole, and then you go to systemic suffering.
And, why leave them on for so long? Keep the cancer off guard. Because we don't know what to do. So the best thing we can do is keep them off guard, because we don't know enough about. There's some good stuff coming out on neuroendocrine disease and how to treat it, and this DLL study that Misha and Rahul are doing and targeting it, but we just don't know what to do.
Yeah. Oh, that's the
So,
place we get stuck in that place. We can try
well,
these ideas of taking a holiday, switching up to the drugs,
well,
versus
one,
waiting if there's a better
well,
research
one,
coming out.
one thing I can't guarantee it, but I can tell you fairly well that when things change, you're going to have a very tough time unless you get off of the darolutamide for a while. It's like with Dennis. Dennis finally
Yeah,
decided. Yeah, go ahead, Dennis. You got your
yeah,
hand up.
yeah. The other evidence out there about intermittent treatment. There've been several studies done where they show conclusively that you don't do any worse on intermittent treatment
Right,
from a longevity standpoint versus continuous treatment.
right.
So having that information, well, what else we know about it, it's a little more convincing factor to do intermittent treatment. I think that's the
Got
thing that scares you the most is, gee, this thing was working fine for me. Now I'm going to stop taking it. Yeah, your PSA is going to rise for sure at some point along the way, and then you have to go back on the treatment again. And
right.
that for some people can be kind of scary, but with the evidence showing that you're not going to do any worse, and there's a likelihood that you're going to also do something to help stall off the morphing.
Yeah, no, I question the solidity of that evidence, of what that evidence really means, that you're not going to do any worse. Or it's like, how much studying have they done about how long the holiday is, how often you went on holiday, how was it compared to a study group? I don't think any of that stuff
They've
actually.
done it. They've done it, Larry. You've just got to do the research and get in and find it. I can't quote you off the top, but they've done it. Time and again, there's been so many studies on intermittent, and you don't do any worse. And it's been studied to the nth degree, but I can't quote you, and Len can't quote you the studies right now, but they're all out there. Now, if you don't believe them, that's okay.
Not
But you can
believing.
say, I don't believe them, but the studies
Oh,
have been done.
I will have the discussion with my doctor and think about whether it's advisable.
Dennis has seen them, Len's aware of the studies, and
Yeah,
we believe it's non-inferior. At the same time, staying on the same drug for an extended period of time is going to put you behind the 8 ball when you want to change.
that's possible.
And that's the scariest thing, because everybody says, oh, but I was feeling fine, and and now all of a sudden it's not working and nothing else is working, and then we don't know what to do. All right. I just want to
That's
I
up on this. Thank you.
okay. And Len, if you've got if you've got the time and the inclination, send Larry some of the intermittent studies.
Okay.
Okay.
Sure.
Bob Pefdal, anything else that we can do for you? I think that, where we sort of left it was follow what Dr. Allen is going to do. Let's do the PSMA. Let's see what that says. Come back next week and tell us when you got the results, and we'll try and give you the questions to ask Dr. Allen.
Sure. All right. Can everybody hear me now?
Yes.
Yeah, I guess you can. I don't know what happened, Rick. My screen, my block went dark, and no volume. I went back on, signed on after a few minutes, and then 10 minutes later, just popped back on, but I can't get the audio to work, or the camera, I mean. And so
Okay,
I want to apologize, everybody. I didn't mean to drop out
no,
in the middle of everything like that.
you're fine. The best thing to do, I want to put it on the recording, call GoTo. We cannot give technical support. If that happens, you've got to call GoTo. It's generally something to do with your local internet that freezes.
Okay, good. All right, well, I know it's gotten late, so I'll be happy to meet with you next week and hopefully have more information.
Okay, our perfusionist is on his way out. So now I got to think, who the hell was the other person that was studying? Somebody's kid was also, other than John LaHaye, John Silverio. Somebody's kid was studying to be a perfusionist. I think it was somebody down here in Arizona.
I have a question.
We know. Yes.
If you have two fusionists, do you get confusion?
But these are perfusionists.
Oh, okay.
So, perfusionists. So, if you have two perfusionists, what do you get? What do you get if you have two perfusionists, Mr. Hack?
You get two crazy people.
Oh, no, you don't. A triple bypass, because I just had one.
That's right. So let me just tell you, this is on the record. Let me just tell you, when Captain Jim needed a triple bypass in June, it was in June. Was it June you did it?
March.
May?
March.
When he needed that triple bypass in March, what we did is we got hold of our perfusionist, and he was trying to figure out who was the best surgeon. We got hold of our perfusionist in Maryland, and he called the perfusionist in Virginia, and we verified that the surgeon Jim was getting was the best one.
Right.
And that's what we do at AnCan.
Well, I would be happy to refer you guys if there's anybody in the Pacific Northwest all the way to Southern California. But you also want to pick your cardiac anesthesiologist.
Yeah.
That's the guy behind the curtain you never see, but they have a big role in this as well.
Okay. All right. Well, Brian, come back.
I will.
Bob, come back. Henry, come back. Henry's gone already. And hopefully you'll all come back to Ben next Tuesday. And that meeting is earlier. It's 2 hours earlier. And the Tuesday meetings are 2 hours earlier than the Monday meetings. Okay?